Hello, everyone, and welcome to another episode of the Masterclass series from the Center for Pediatric Psychology at Oklahoma State University. In this series, we will be meeting with different health professionals and stakeholders to discuss topics and provide resources, with the ultimate goal to help pediatric psychology professionals, trainees, and caregivers navigating healthcare for their child. And on to today's episode. Hello, everyone. I'm excited to share this enriching masterclass episode on bridging clinical practice with psychosocial research from Dr. Lori Wiener. Dr. Wiener is a co-director of the Behavioral Science Core and head of the Psychosocial Support and Research Program at the Pediatric Oncology Branch of the National Cancer Institute. As both a clinician and a behavioral scientist, Dr. Wiener has developed a robust clinical and research program that has focused on critical clinical issues such as parental coping, lone parenting, transnational parenting, emotional consequences of medically required isolation, sibling and sibling donor experiences, graft versus host disease, and end-of-life planning. Dr. Wiener has also dedicated a substantial part of her career to applying knowledge from her clinical experience and psychosocial studies to create innovative resources such as books, workbooks, therapeutic games, and an advanced care planning guide for children, adolescents, and young adults. Each of these resources are distributed worldwide and widely utilized in pediatric centers. Dr. Wiener proudly led the team that has developed the first evidence-based psychosocial standards of care for children with cancer and their family members. She has published extensively with over 250 publications spanning peer-reviewed papers and book chapters. Dr. Wiener has co-edited the textbooks Pediatric Psycho-Oncology, a quick reference on psychosocial dimensions of cancer symptom management, and Pediatric Psychosocial Oncology, textbook for multidisciplinary care. Co-authored a storybook, The Gift of Gerbert's Feathers, to help children through the psychological and behavioral process of preparing for a natural end of life, and is currently co-editing a special issue of Children on psychosocial issues in children and adolescents living with a rare condition. We hope you enjoy this masterclass from Dr. Wiener.
Okay, here we go.
All right.
So our psychosocial support and research program has three overriding aims. The first is to provide excellent psychosocial care in the form of clinical services to patients and families to help them enhance coping and adaptation. And that could take place through many different kinds of targeted or therapeutic interventions that are offered both in our inpatient and outpatient services, as well as programs for staff. It's from the issues that are identified during our clinical services and programs that the research program emerges. And this component consists of the design and implementation of novel psychosocial studies that can best be carried out in our intramural program. And I could be happy to be able to talk a little bit more about that. And it includes studies where we are either the lead sponsoring institution and those where we are a participating site. And we also support our esteemed colleagues in developing secondary objectives for their medical treatments, mostly in terms of quality of life. And the third aim is then to translate the information gathered from both the clinical work and our research findings to develop, implement, evaluate, and disseminate new resources that then could become available for the rest of the world. So what's really important here is the continual integration between the clinical services, the research, and then what we develop. So I'm going to give you just an overview of some of our portfolio. So we have studies that fall in these different areas: reliability and validity of measures, developing them. I'm going to give you one example with the distress screening to identify unique sociocultural factors. And Dr. Mullins was part of an early study with looking at lone parenting, but we also looked at international parenting. We looked at the impact of cancer on a parent's partnership. And the third is really to improve quality of care. And we have a number of studies that fall into that area. And I'm going to give you one example of that as well. So the first project I'm going to talk about is the development of a distress screening tool. And I'm sure you're familiar with the fact that distress should be measured as a sixth vital sign. This has been endorsed by many different organizations. And also, distress screening has to meet some accreditation standards and is considered to be best practice. And that was one of the first of the psychosocial standards of care. The problems in pediatrics is that identification of psychosocial problems is often delayed. When the clinic is busy, families are going from scan to scan. They are just coming together for maybe a family meeting and then going home. And it's not until they really have an active problem or maybe an issue with adherence that it comes to our attention. And with fewer resources, not every child can even be seen by mental health providers. So we wanted to be able to find a brief measure to identify those who really needed help in that outpatient setting. So we developed first the study, which has had 3 different phases, and I'm going to take you briefly through each of those. And I think that it will speak to the importance of how long some of this research could take, but how important each step along the way is to really good research. So the primary objectives of the first phase is to assess the validity of an adapted pediatric distress thermometer. And we did that by looking at some gold standard measures of anxiety, depression, pain, and fatigue. We also wanted to assess the inter-rater reliability among different respondents, and then to determine how acceptable and feasible it is to administer this within an outpatient setting. Our eligibility was for ages 7 to 21. And this has been published, so you'll have the resources, the references for all of this, but we had 289 triads. So both a parent, a child, and a medical provider. About 60% were Caucasian, and about 3/4 were the mother. And if you haven't seen a distress thermometer before, you could look at low, moderate, and high distress. And you can see that here in green, yellow, and red. So let's say a person says that their distress, and we define it for them, in the last week was a 5. Then we ask them, was your 5 because of any emotional problems? And here you see a listing of those. So let's say they say, yeah, I've been worried and I've just been angry. And we ask the same for physical problems, practical problems, spiritual problems, and family social problems. So here you could see that they said, yeah, I've been having nausea. School's been stressful to me. Taking medications has been stressful. Some spiritual questions, dealing with my parents or dealing with friends. You can get a sense of how clinically meaningful this can be. But then again, I said that we looked at a parent, a child, and the medical provider. And here you can see a parent who said the child had low distress, but really did endorse things about sadness, irritability, was upset about losing their hair, some issues with school, and dealing with parents. The provider thought the child had moderate distress. And here the patient themselves gave themselves a high distress. And if you look at what was endorsed, some of the stuff in red is the same, but they also endorsed other areas, the anxiety more than the sadness, other issues that were going on in terms of medical, physical problems that were really upsetting to them or distressing to them, as well as feeling distant from God, some spiritual concerns. And in 43% of the cases, we found discordant ratings. This is really important because if you only had the parent perspective, then you would assign or consider different interventions just based on that. So a summary of the first phase of this is that we found it was quick to administer. We found concurrent validity with all of our gold standard measures. We asked for benefit burden and found it to be a really low burden and perceived benefits for being asked about those issues. It was acceptable and feasible, and it was useful within a wide developmental range. And I have here 8 to 21 because the 7-year-olds were just too young. So the limitations, though, they found is that a lot of symptoms were endorsed. And if you are undergoing, let's say, cancer, and this population was not just cancer, it was primary immune deficiency, some sickle cell, leukemia, and a few other conditions, they're going to have a lot of symptoms. And so what do you do with all of that? So we wanted to be able to think about something that is, which symptom is really interfering with your life? We also found about 8% endorsed suicidal ideation. That was concerning to us on the children's depression inventory. And while in interview, very few of them were really suicidal. They were somewhat pretty sick and had thoughts about what life would be like for their family if they were no longer alive. So we felt it was important to be able to make sure we do ask about that in a distress screening tool. Kids hated the word distress. They said, "You're distressing us by asking about distress." It was not currently available electronically. They were tired of being able to be able to answer things with paper and pencil. And we needed a way to get this back to the provider pretty quickly. So the next phase was the development of a revised distress screening tool. And we had partnered with the cancer support community for that. And we wanted this next generation to look at items that were most often endorsed, those where we found a lot of high discrepancy, symptoms, as I noted before, that really interfere with quality of life, something that was brief and we could use skip patterns to reduce burden. And we wanted to make sure that we had a caregiver version as well as the child version, and something that can give real-time feedback to the providers. And we started with cognitive interviews. So we came up with our items that we wanted to be able to include. And in in-depth interviews, we asked in the different age groups about the accuracy and quality of the items. And by doing this by several questions, like, what do you think this question is asking? And how did you choose your answer? And how would you change the words to make the question easier to understand? And we got a lot of feedback, suggested wording changes. It could even be when we talk about sleep. Well, what are you talking about? Falling asleep or staying asleep? More understandable language that we may use for cognitive issues. They use different wording. When we looked at adherence, it may not be just physical, pill swallowing. It could be other things, just like, emotional reasons for not wanting to be able to take their medication. We also had a lot of feedback in terms of what the design, the format, and the response options should look like. We have a body, and which I'll show you, where they can mark down where they have pain, but for people, they just wanted more specifics. Is this the front? Is this the back? 7 days. They definitely didn't get a month. For 7 days was even confusing. So we changed this to the past week. A lot of people who had difficulty reading wanted an audio option. And for some of the items, we ended up using primarily, they wanted to have colors that could be where, like red would be more distressing. And we ended up in domains such as in physical, emotional, cognitive, social, spiritual, and practical. And we also ask if they feel like they're getting the support that they want or need. So this is just going to show you a snapshot of what this looks like. So again, it's called checking in. It says, "Hello, welcome to checking in. The following questions will help us understand a little bit about how the past week has been going for you." And here they could be there's a question that asks, "How much has pain been a problem for you?" And you could see they could use the glider to be able to say how much this has been a problem, from no pain to the worst pain I could imagine. If anything is endorsed, they get check boxes. In what ways has pain been a problem for you? And here it can be, I've had too much pain to do what I want to do. I've had trouble sleeping at night because of my pain. I've been more emotional, sad, stressed, irritable because of my pain. And then they have a picture of a body where they could be able to mark down where pain has been a problem for them in the past week. So for all the other items, we have a scale that looks like this. So how much is feeling worried or scared been a problem for you in the past week? And it could be from not at all, a little bit, sometimes, often, or almost often. If anything is endorsed, except for not at all, this will come up. They will then just have the check boxes that will just that they could be able to put down in what way sleep has been a problem for them. So this is a way they could say whether it's falling asleep or staying asleep, other thoughts. And there's a place they could type in as much as they would like to type in if something was not captured. Same thing for taking medications. Here's an example just about some of the ways that taking medication may have been a problem for them in the past week. As I noted, we wanted to be able to include suicide screening, and I'll show you an evidence-based screening tool that was actually developed at the NIH. But when we asked about suicide, sometimes they weren't suicidal, but they endorsed having thoughts of hurting themselves without wanting to die, such as cutting. So we have one question that had been validated about that. And here is the ask. This is the measure that had been developed at the NIH, actually through the NIMH. This has been tested and validated in thousands of children in medical settings and in outpatient and in emergency rooms. So here they have 4 questions, and it is: in the past week, have you wished you were dead? In the past few weeks, have you felt that you or your family would be better off if you were dead? In the past week, have you had thoughts about killing yourself? And have you ever tried to kill yourself? If any one of these is endorsed, then another question comes up that says, are you having thoughts of killing yourself right now? And we include this for children who are 10 and older. Once they've completed checking in for those different domains, a summary report is available, and you can be able to be printed. You could send it to the people that you want to have this. And you'll see over here that in green, just nothing needs to be done. In yellow, it means somebody put down a 2 or a 3. So it can be a little bit of a problem or sometimes a problem. And then in red, if something is often or almost always a problem. And then you could see popping up really strongly in red if there's self-harm or suicide had been endorsed. The nice part about this is that you also can go back to the past 5 times that it's been administered. So you can see how the symptoms have changed over time, what that trajectory looks like. And it also provides the different items. I couldn't put it all onto one slide, but the different items that were endorsed, what they said, how those areas have been a problem for them in the past year. So we have that, and then we started another study, which is the next phase, to looking at the feasibility and acceptability of checking in. And we wanted to see what that was like for our pediatric patients and their caregivers. We want to look at how beneficial or burdensome it was to complete in an outpatient setting. We also wanted to look at the usefulness of the checking in summary report for the medical providers once they have the summary report, and to be able to look at how acceptable it was to patients and patients and their caregivers if we ask about suicide in the outpatient setting. So these are just some of our participating centers, the 4 hospitals that this is open in: Hopkins, Levine, Colorado, and at our site. We had 134 dyads. You could see that a few in the 8 to 9-year-old, and then we had the rest in the 10 to 21-year-old. As I said, we had some of the items were slightly different between the 10 to 12, 13 to 17, and 8. And the 13 actually to 21 is the same, but we didn't ask about suicide screening in the 8 to 9-year-olds. And asking just about how easy or hard it was to complete checking in a pediatric outpatient setting. Most participants rated that it was easy or very easy to complete. Most participants rated that the amount of time needed to complete the measure was acceptable. They considered it feasible as well, as you could see by the numbers here, for both the patients and for the parents. We got some barriers, clinic issues, timing and the flow and space, especially during COVID. We want to be able to have the parents and the child separated, and we don't have a lot of extra space during that time. Some needed a little extra help in terms of tech support, but those numbers were pretty small. To the question, should healthcare partners discuss having suicidal thoughts in an outpatient pediatric setting? You could see over here that was predominantly the patients and parents thought that this is something that should be asked. And to the parents, we asked them, would you know as a parent if your child was contemplating suicide? And where you see here about 2/3 thought that they would, a few thought, 9% thought that they wouldn't, but about a quarter weren't sure. And so this was really important. And it turned out that for some of the children who did endorse suicide, the parent actually did not know. Again, why it's so important to be able to ask these questions. We also found from the providers that over half of them changed their care for their patient based on what they found on the screener. For the majority was just having more conversation about what those symptoms are like for the patient and the parent. Additional referrals were made, and some changed medication, or just be able to restart some medication that had been stopped. So, in summary, the checking in was acceptable and quick from the participant perspective. It was 10 to 13 minutes, but I could tell you that for some of them, it was a lot shorter. Remember, this was during a research administration. It was feasible in an outpatient setting. It was very helpful in detecting suicidal ideation and self harm. It clearly provided clinically important and sometimes otherwise unknown data for the healthcare providers and sometimes change the actual course of treatment. It's delivered in a format that they're familiar with. They could use this on their, if they want to, if we wanted to send them the link, which this was not done. This was again in a study format. So we had an iPad that we provided to them, but it can be within a phone or in different kinds of tablets. And that platform is just very flexible because you could do this in clinics. You could do this as an inpatient, but again, this was an outpatient study. And the cancer support community has an adults tool, screening tool that is integrated in the electronic medical record. This is under review right now, this part of this study. So at that point, what I'm going to do is just go back and I'm going to stop sharing and to see if you have any questions.
Thank you so much. That was so interesting to see the different phases from sort of developing the measure and then fine tuning it for that population. And then, okay, now how is this useful and getting that real time feedback? I guess for the follow-up portion of referring, I noticed when you had like the green and the yellow and the red, so with that discordance between like the parents and the patient, how are providers, I can imagine psychologists and mental health providers might get that information and make referral decisions differently than maybe some medical colleagues. So I wasn't sure what your thoughts are on kind of reconciling those two and steps to move forward for families.
Yeah, that's actually an excellent question. And our fellows, our HEMONC fellows, definitely were challenged by that. They said, I don't know what to do with this because I have a child saying this and a parent saying that. I don't know how to introduce that conversation. And that's a training,
Mm-hmm.
opportunity really to be
Mm-hmm.
able to
Yeah.
say, I noticed that, Sammy, you said you're having some problems sleeping and your mom is not thinking that, or, Sammy, your mom thinks that you're having some problem taking your medication and you didn't think so.
Mm-hmm.
I was wondering if you could help me understand that,
Yeah.
just to be able to get a sense of that. Sometimes it's a symptom, and this is where when you get into trouble, when you talk about interference, sometimes the child could be pretty concrete about, well, I have that symptom, so, but it's not interfering with my life. Or they could be very clear.
Mm-hmm.
It says it's, the mom says, I know this is a problem for you, but it says, yeah, but it doesn't bother me. So it's, it's an important way to be able to decipher that. And they may have gotten so used to it, it may be a lack of appetite, which we don't have in here, but it's it may not be a problem for one, but it is a problem for the other. So again, to be able to just have that as an opportunity for discussion.
Mm-hmm.
From this next phase, what we're going to do really going into the next phase, which I didn't present from here, is that for the 13 to 17-year-olds, there's some 13 to 21-year-olds, there are some items that may be of interest that were not in here. So we have a checkbox as to say, are there other issues that are, problems that are, or issues that are on your mind? And they could just check that off. So maybe it is gender, maybe it is identity, maybe it's relationships, it could be, substance use, it could be other things that they could be able to just to be able to check off. And that will be something that we haven't tested yet. In the next phase, we're going to do that. In the next phase, what we're going to do as well is we're going to have a qualitative interview with a certain number of participants in the different age groups afterwards to see how much in the interview, what they share about their findings, to be able to say, this is the things that you endorse. Did this really capture what it is that's going on in your life right now? And was there other things that were going on that wasn't captured here? So again, many different phases, but this is going to become commercially available through the cancer support community within this year. So any site could be able to obtain it for their own programs, and it could be tailored really to each program. So we had referral sources, but those are referral sources at NIH. Your site may not have that. They may have other child life where we have rec therapists. You may have a different kind of triage system. So you could be able to have it created. Each hospital could have it created for their own population and the way that they do their triage.
That makes a lot of sense. Like using this tool to generate conversation, and then each institution is going to have their own way of following up on those things. And it seems like widening the tool in the coming phases as well, it takes advantage of a lot of families seeing specialty care as kind of their main medical provider. So it's like, okay, we can widen our lens to try and capture while they're here, knowing that those conversations might not be an opportunity in a primary care setting if they make it there, and they're just seeing their specialists instead. So that makes a lot of sense. And I can imagine for the adolescents and young adults that helps kind of taking ownership of one's own medical care, and also generates that kind of transition conversation as well.
Exactly.
Really cool. Awesome. I can't wait to hear what else you have for us.
Okay, so let me go share my screen again. This next one has also been a very long time coming. And it's one of my favorite studies. So this is the development, it's the development of an advanced care planning tool. So I think you may be very familiar that few children living with a chronic illness have an advanced directive. I think one of the papers showed less than 4%. And yet families want to be able to have some of these really challenging conversations with their children, but don't necessarily know how to be able to do that. And the majority want their child to participate in decision making as well, but not really sure how to best be able to do that. We have found, as long as many others, that adolescents and young adults view that lack of information given to them as a major barrier for being able to have a voice in what's most important to them. But they sure do have a good sense of what they want and what they don't want. So this began by first part of the study is to explore whether adolescents and young adults living with a life-limiting illness were even interested in having a developmentally appropriate end-of-life planning document. And even if we didn't call it end-of-life planning document, but an advanced care planning document. So we started with the focus groups with just 20 participants. My IRB at the time was very, very cautious about this. They didn't want me going over 20 patients. I had to start, couldn't go under the age of 16, but we asked them to critically evaluate whether the concepts included in 5 wishes and the focus groups. So in the focus groups, people came up with items that they thought were going to be helpful to be able to have in such a document. And they also thought it would be a great idea to have it. So we had them go through page by page of 5 wishes, which is the only advanced directive that has items in addition to just who do you want to make medical care decisions for you, or what kind of care would you want in terms of if you would want life support or not. And also asked about different items, which you'll see in here. So we asked them how helpful the items were to themselves and other people their age living with this serious illness. We asked how appropriate it was to ask individuals their same age about these type of items, and how stressful it was to contemplate. And then we also asked them to rate which items or wishes in there were most or least helpful, and what question statements should be added or removed. So, in the first phase, everyone thought that this would be appropriate for adolescents and young adults living with any serious illness. We found that 90% thought it would be helpful for others their age, and 95% thought it would be helpful for themselves. But we got a lot of comments back that what was missing from 5 wishes, and items just like, where I would want to be if my end of my life was near, or how, if I wasn't to survive, how I'd want to be remembered on certain days, like on my birthday or certain holiday. I know that my parents are just going to bury me in a fancy suit, and that's the last thing I would want to be able to be buried in, and who I would want to come to my funeral and who I wouldn't want to be able to be there. Or they just are very religious and I don't, want something like that, or I want something like that and they wouldn't want something like that. Who you want to be able to receive or go through your belongings, things that, what you would want a service to be, but mostly just about other parts, about just that their life was meaningful. So we created a new document that took into account the importance of both the family and peer relationships and that need for intimacy, and the capacity for independent decision making. And it was called My Thoughts, My Wishes, My Voice. And then we opened up, the IRB was a little more comfortable. We opened this up at Georgetown as well. We had 52 participants. Average age is 20, and we had them critically review both of the documents. And again, asking how helpful each item would be to complete, how stressful each item would be to complete, but a lot of information on their preferences for what the document should look like. Should it be check boxes, open-ended? Should it be what kind of colors, as well as what the content should include? And over again, we found the same themes coming up: the importance of identity, meaning, spirituality, family, friends, wanting a sense of control and autonomy, and making sure that their life really had meaning. Those were the key developmental issues. So with that in mind, and going through what we heard in the focus groups in the first phase of the study and the second phase, we created a document called Voicing My Choices. Voicing My Choices is about saying what makes you feel supported, write what decisions bring you peace, to choose what provides you the most comfort, and a place to voice your thoughts and needs. So just to give you an idea of some of the pages, every page is, you have both my voice and my choice, because that was important to them. There's a little bit to introduce on the top of the page, but then we published just a way to introduce each page. And so this is just an example. When you don't feel well, what tends to bring you most comfort? Do you like the room dark? Do you tend to want to listen to music? And here's a page where you can share what you find most comforting, so that others can know without you having to tell them. Or a page about what I would like my family and friends to know about me. Many people your age have told us that they tend to worry more about other family members sometimes than they worried about what's happening to themselves. Has this ever been the case for you? Is there anyone in your family who's having a really hard time? What worries you about that person? What about your friends? Is there anyone you worry about the most? Someone you would want to say something to, but not sure how, like something a friend might have done that was especially cool and meaningful, or something that you might want to say, but that you're sorry about. Just the whole idea of forgiveness. And here's a page where you can be able to do that. And then you just invite them to read it and to be able to see if there was something they wanted to complete. One of the more difficult pages is how I would want to be remembered. And for some people, this is the what ifs when they go to sleep at night. If I wasn't to survive, how I would be remembered, what I would want. So they have the option here, just in terms of they want a funeral or a memorial service, if they want to be buried or cremated, if they would want to have donate part of their body or have an autopsy, an open casket, closed casket, instead of having your family be brought a million different casseroles, if there is someone you would want, or a place that you would want contributions made, again, who you would want to go through your belongings and how you would want to be remembered on certain days. So this came out at the very end of 2012. We signed what's called a material transfer agreement. So we created this, we did the research, and we gave it to the organization called Aging with Dignity, which has 5 wishes, and also a young version called My Wishes for Young Children. And we were just really surprised by the need for this. At this point, there's well over 54,000 copies distributed. It's available in several languages and in 42 countries that requested this. It even showed up on the front page of the Sunday New York Times. in 2015 with the actual picture of, some of my writing in it, with a family who participated in there. So clearly there was a need for this. And you would think that that would be like, this is great, but I was really concerned because I was getting a request for people in their 30s. They said, what about us? A document created for people 65 and older is not appropriate for me as well. And I never asked some difficult questions, well, what does voicing my choices do? Does it increase anxiety? Does it decrease anxiety? Does it open up conversations with family members and friends? What about acceptance of illness? And so I created another study to be able to answer some of those questions and opened it up in 7 different settings to centers to be able to, again, to be able to see about the perceived helpfulness of voicing my choices and some of those different domains. And here we enrolled patients who are 18 to 39, the NCI definition for adolescents and young adults. Actually started 15, but for the IRBs, it was just more comfortable looking at adults. And again, since we were having so many people in their 20s and 30s ask for this, this looked appropriate. At baseline, they answered a few measures on communication, anxiety about end of life, planning, acceptance of illness, and social support. They reviewed every page critically, and then they completed 3 pages. And then we followed up with them a month later. And we asked them to complete those measures again. And then we asked them, did you share this with anyone? And if they did, we asked them whom they shared it with and what that experience was like. And if they didn't, we asked them why not. And so we were able to elicit some of the barriers to that. If they did, we asked if we could actually interview their family members or the healthcare providers that they spoke to about their voicing my choices. And what we found over here is that half of them had not previously discussed their wishes or preferences about end-of-life care with a family member. And after the study, 65% of them then shared their pages. The majority had not previously discussed their wishes or preferences with one of their healthcare providers, and very few after completing this study the month later had done so. For many of them, to be fair, this was only 1 month later, and they said they hadn't had an opportunity to have this conversation yet. But more likely, and what we heard a lot, is that they think that the provider should be raising it with them, not them raising it, the issue with their provider, not the other way around. One of the most important findings I think we found is that anxiety about advanced care planning or end-of-life planning decreased significantly between the baseline and the follow-up. And I say that that's really important because what comes up is that the providers would say, well, it's going to make them too anxious if I raise that item. If I start talking about advanced care planning, and in actuality, again, their anxiety was decreased. Over 90% reported the items to be helpful. They did suggest several changes, and I'm going to show you a few of those. And this is now was published recently. And these are the different sites that participated in this study. So creating a revised document, when we had over 25% after the first 100 patients went through this, when over 25% of the participants recommended a change, we made that change. We actually created a few new pages, not only revisions to existing pages, and we really partnered with a lot of people, including an ICU physician, our palliative care group, and more chaplains. So we'll see over here that there are more pages to what we had before. And just to give you a sample of just some of the changes that were made, like on comfort, people wanted to be able to, things talked about sensory experiences, about the lighting in the room, the decoration in the room. They wanted pain to be upfront, really important about how they want their pain to be treated. So, some people just snow me. Other people would say, well, if my pain is over an 8, then you could snow me, but I want to be alert. We had, in terms of support, people just talk about, there are times I really want to be without visitors. I want to be alone. They had a lot of feelings about how information about their care should be shared. In terms of spirituality, they wanted an option for family members to get spiritual support, not just for themselves. In terms of the life support treatment, that was the pages that ended up having the most changes. Over here, the original had 2 different scenarios if they were close to death. And above it, everything you see in blue that's underlined, there's a glossary in the back. Well, some of those items just didn't resonate with the adolescents and the young adults. And so they wanted more of a hierarchy that could start with some of the interventions that are going to be recognizable to them. So again, they wanted, different scenarios. They wanted things that were going to not be felt so negative. And they also wanted to say, well, what if I've already completed a document like this? So here you'll see that one page is now 2 pages. And here's the hierarchy, starting with like catheters, a placement of maybe tubes, which is obtaining urine or stool, antibiotics, medications for pain and anxiety, if they've ever had a blood transfusion, or performed surgery before you went into something more like a CPR. And there's now 3 different scenarios. And the first scenario is that treatments are available that may cure or improve my disease or disorder. The first option is I would like life support treatments provided to me to help me survive, but they may still not want to have any kind of life support treatment. And so that option is there. And then those other scenarios that you saw before are included in the second. And then the third is where I wanted everything done. I really wanted to be on full life support, but what if, there's weeks later and I'm not getting any better? Then the staff is stuck if someone said, I wanted everything and what to be able to do if their voice can't be heard. So here they have an opportunity to say what they would want, if they would want their goals of care to be reevaluated, whether they would just want to continue to have life support. So there was also a request to have personal information. So here is a page where they can be able to put down passwords or bank account information, thoughts about how their social media accounts or other personal information. For example, what if I did sperm banking? What would I want to happen to that? And for those who have children of their own, they now have a separate page to address how they would want their children to be communicated with and to be cared for. There's pages in the back where people could write letters. People found that just too overwhelming. Like, where do I start? So clinically, what I have done is I have worked with people to be able to say, give me a list of people you would want to write a letter to or say something to, even if you think you could never do it. And they can give me a list. And I say, they're all difficult, but who out of this list would be the least difficult? And then I offer to go with my computer and say, how about if I just ask you a few questions and you just answer the questions, I'll type them up and then I'll send it to you and you could just edit them. And some of those are like, writing this letter is really hard to do. You've been so important to me because I will always especially remember. Or in the future, if you ever get really sad, I want you, as I said, to really always remember, and something I really hope for you. And they really like that idea. So we have one page now, there'll be lines in there, and then many other pages that will still have for their reflections. If they want to put down more comments for something in the document, if they want to be able to put down poems or recipes or anything else they want to include. So the next phase, again, fifth phase, is study is open. It just opened at Children's Hospital in Irvine and at Johns Hopkins. We're going to be having 50 participants who are going to review the original document with this new document. We will carry out the same kind of qualitative analysis and comparative analyses, and we will provide a final version back to Aging with Dignity for distribution. And we're working on funding to have this become a digitized version. Something that's been really fun is to be able to work with colleagues around the globe in terms of cultural adaptations. It is not just a translation. And so you'll see we've been doing this now with Brazil, Australia, although it's English, they still have very many cultural differences, and in China. So in Brazil, there were a few things that were just very different. They don't have celebration of my life. This doesn't apply to them. And I'm just giving you a snapshot here. In Australia, they have a younger population that they wanted this for. The colors that we had in dragonflies, that just didn't resonate with them. They added other things about me at the first page. They had my bucket list and my care. So just stuff you need to know about me being young. Again, as I said, my bucket list, how I would like my online presence to be managed. So they have a lot about online presence. who I want to share my voice with. And here's just the pages, but it's all in their formatting right now. And in Beijing, they started with independent translations, and then they created a synthesis document. And they really wanted to look at how they could introduce this in their country, in different parts in Beijing. There's now 2 versions in different parts of China. And they look very different. So they went to the providers, and they got a lot of feedback from the providers before they went and started interviewing their adolescents and their young adults. And the background here for their cover page is I think just beautiful, but it's the colors that resonate and most meaningful. And you'll see they use a deer on each of the pages as their main element. And deer is painted in the Chinese ink style, as it is a symbol of happiness, peacefulness, and kindness. And as you can see over here on the left, in Chinese mythology, deer is a god or an auspicious beast. So you can see how their pages look a little different. So just to be able to bridging, I spoke about how our clinical insights could generate research findings, and now we could then take those research findings, translate them into new resources that are then implemented, evaluated, and disseminated. These are just some of the documents that we've created using this type of procedures. We also have something, feel free to check this out on our website, which is just a place for pediatric psycho-oncology professionals to come, and you can put in a very brief little bio or just a profile, and you can get to see what's new and noteworthy around, a way to connect with other people that may have similar interests. I share one thing that came out right before COVID. It was terrible timing. We wanted to be able to find books for children who may not survive their illness. And there's a ton of books on loss and bereavement. So we did a search, and part of that search was looking at what we could find. And in the end, we only found 5 books that are appropriate for a child who may not survive themselves. And so we wrote our own, which is available, called The Gift of Gerbert's Feathers. And so there is online tools and communication tools that are included in there for parents, for siblings, for teachers. There are arts and crafts activities. It's online that you can get for free online, an audio version of the book. And that is all I have. And any questions? So I'm going to stop sharing, and know we've gone on for a bit of time, and I look forward to your questions or thoughts. I gave you a lot of information.
Yes, you did. Incredible, incredible. It's really cool to see like the Voicing My Choices and 5 Wishes stories, because I know so many folks use that clinically. And I guess one question regarding that, and then maybe we can zoom out more big picture, is if you got any feedback from any of the participants or stakeholders about when they wanted that tool implemented in their course of treatment, if that was something that was ever mentioned.
So you've asked really excellent questions. That wasn't part of the study, but we have in other areas, in other research that we've done. And in general, this is not something you were going to introduce at time of diagnosis.
Right.
But we do feel that it's an important thing to start broaching, not necessarily handing that Voicing My Choices, but start broaching these issues at the start of treatment. And it could be broached in a way that we anticipate treatment is going to go well, and we're very hopeful. But we've learned from experience, not asking some challenging questions has been a problem or a mistake for us. So have you given any thought, if something happened and you had a sudden event, or who you would want to make decisions for you if you weren't capable for a period of time? Or do you have any strong feelings, religious feelings or other, feelings about how aggressively you feel comfortable being treated? Some people, are not comfortable with blood transfusion. Some people are not comfortable with an intensive care unit. Have you given any thought to that? Or I would just recommend you don't have to give me an answer now, the things that you could think about. And then you could be able to then come back. You've now paved a road to have that kind of conversation. So if the child does have an event, or the child, a young adult, or or, treatment is not working, or there may be some progression or something else comes up. And you'd say, do you remember when I asked about, and you can go back to that conversation.
Mhm.
Say, we have next treatment. These are the things we're planning. So again, you don't have to give me an answer right now, but this is a good time just to think about these things. Anything I should know to make sure that whatever we do has your special stamp of approval,
Mhm.
that is really based on your goals of care. And to open up that conversation again. And that's a time when you could also be able to say, there was a document that was created by and for people your age to be able
Mhm.
to help with these kinds of, issues. Is that something you would like to be able to, to be able to visit or to be able to see? And then I would send that over to whoever the psychosocial provider is. And generally that's going to
Mhm.
be the psychologist or the social worker. It's going to be different in different sites, maybe the chaplain, to be able to go through it. I would not just hand it out. I mean, some places give it out
Yeah.
or transplant, or before transplant is a very important time, but not just to hand it out, but to introduce the different pages. Because for some people, maybe just the page about spirituality is the only thing they care about, or pain, or may only be if I just don't survive. Some people are going to want to be able to talk about comfort, or, and their family and their friends. But a lot of times they'll go through and say, I haven't thought about this, or I did think about this, but I didn't know how to bring this up.
Mhm.
Or I wanted to be able to talk about some of this stuff, but I was just going to upset my parents. It's just going to make them too upset. Or, I want to be able to, or their parent may be thinking about this, but they didn't know how to be able to raise it with them. And so it's just a tool to be able to say, can
Mhm.
I share this with you? Hold on 1 second. I have a roommate here. I have a 4-legged roommates here today.
Such a Zoom life these days.
Does
Yeah,
that
I
answer
hear.
your question?
Yes, I hear this theme of just like we're generating conversation. We're providing some tools that clinics can use to get these tough conversations started and support families in this really holistic way, which is
Exactly. Yeah.
such an honor to be able to do.
Yeah,
Very
absolutely.
exciting. Well, then thinking about this sort of clinical and research, I want to use the word pathway, but I don't think that's even right because it's a cycle that kind of informs itself and just continues to grow. Um, what advice or thoughts that you've learned throughout that process that you have for maybe some earlier trainees or early career psychologists who are interested in having that through line of taking their clinical experience and applying it to research and then back and forth throughout that?
Um, yeah, it
The
depends
big
on.
question.
No, it's okay. It really just depends in the culture of the setting that they're in. So in some
Yeah.
places, they're only going to be asked to be able to do clinical work or a lot of neuropsych testing, and they may not have the opportunity to be able to
Mhm.
do much more because of just capacity of how much is going on.
Mhm.
But whenever it is possible, I say start early on. You listen to your patients, and since you have something that comes up that you don't know if there's an answer to. So for example,
Mhm.
I was asked to be able to see several young people who were going to need an amputation. We had an osteosarcoma trial, and I went looking at literature. Is there anything out there in terms of how to prepare a team for an amputation?
Mhm.
Obviously, you have amputation because of war or other reasons, and I couldn't find anything. The only thing that I found out, there's a lot about post amputation, quality of life, or limb sparing versus amputation. So we designed a study to be able to just qualitatively start with pilots, just to be able to say what was helpful for you when you underwent an amputation as a child or as a teen. And just starting with the IB, it's allowed us to be able to do 10 interviews and learning from that, and then to be able to say, what else do I need to know, and what else do I need to grow? Needs assessments. I say start off, if you have a clinical situation and you can't find the information anywhere, that's a great exploratory pilot. But you may not, you may be working with a patient population that you just not really sure what their needs are. You may have, a new trial that's for CAR T therapy, and you just don't know what that experiences can be. So you could start off with a needs assessment, and you could do it as a QI or QA project, and just be able to say, check boxes, and open-ended. What would make this experience better for you? What are the greatest stresses associated with being able to have, to be able to provide this kind of therapy to you? What are the kind of things that we need to be able to know to be able to make this a better experience for your family? And then you could be able to start by being able to take that data and to be able to bring it back to the clinical scenario, the clinical setting. So it is that relationship. It is starting with being able to say, this is what I'm hearing. This is what I'm not so sure about. Here is the data. Let me bring it back. And let me tell you, when you collect some of that data, you are also helping to grow a program, because the sites are going to hear, 55%, 60% feel like they're not having their psychosocial needs met, or they're feeling they're having problems with adherence, and we're not addressing that. So you may be able to get more resources to be able to address that.
Mhm.
So,
Yeah, that makes a lot of sense.
so it is that interconnection though. So it's being able to hear, be able to look and explore, what do we know about this? Go to the literature, be able to see what's out there, be able to say, is this a research question I could be able to ask? What am I learned from that, and bring that back? And that pilot data is also going to be really helpful for you to be able to have when you apply for that first K award, or you apply for your first R13, or whatever you may want to be able to do, or your first ACS award, or grants, your early grants. You have some of that pilot data that's going to help a whole lot.
Mhm. Yeah, that's really great to hear. And it sounds like a lot of going to patients and families and the stakeholders and really having them inform
Always,
whatever you're doing, right?
that's right. Always engage them. I don't have a protocol that I've gone through that I don't have vetted by the patients and the families, especially bereavement studies, to have bereaved parents
Yeah.
and be able to review it, am I asking this in the best way, and just getting their feedback. Absolutely.
Mhm. Is there a certain sort of mindset or approach that you found has worked best for engaging families throughout that research process?
You don't want to exploit them. You absolutely don't. You could put something out there, just even like a little flyer. We need some
Mhm.
expert advice. Anyone who's interested, just let us know. You just may have relationships with people that say, if there's anything I could do to help, or
Mhm.
if there's teens, love to help. You could have an advisory group. Those are always
Mhm.
great. Teen advisory groups are great, just to be able to have feedback. They want to be able to give back, and they learn from each other. And it's a nice support network for each of them. Just make
Yeah.
sure you give really reasonable things for them, to be
Mhm.
able to review, and you give them the kind of support that they need throughout that process. But
Mhm.
yeah, that feedback is instrumental to make a
Yeah,
really good project.
absolutely. Sounds like everything just takes a lot of humility, asking questions, and just remaining open to whatever feedback and what the data and then what people's lived experiences show you.
Absolutely. And I definitely have a lot of short-term studies, but what I showed you today are really long-term studies. And I did that on
Oh.
purpose because I wanted to be able to show the evolution over time. You're never
Mhm.
really done.
Yeah.
You have a very specific, task that you're asking, you're assessing an intervention, and then to be able to grow from that and to make something, available. Like the
Mhm.
standards of care it's going to be a lifelong process into updating
Right.
those. But research takes time,
Mhm.
and there's many steps, and don't jump the steps, because what you learn along the way is so meaningful and so important to be able to make whatever you decide to be able to do better. And the
Mhm.
clinical pearls that you learn along the way, you're going to take with you wherever you go.
Yeah, that's amazing. Thank you so much for sharing your work. It's really exciting, and I look forward to all the iterations to come.
Okay. Well, thank you very much for inviting me, and have a beautiful weekend.
We hope you gained as much as we did from today's episode. You can find more episodes like this on Apple and Spotify podcasts and our YouTube channel. Be sure to also follow us on Facebook and Twitter, and check out our website. Links are in the show description. Thank you for listening, and we hope you come back soon.